Welcome back to our education series on type 2 diabetes. In episode 1, we explored what's really going on inside the condition. In episode 2, we highlighted lifestyle as the cornerstone. And in episode 3, we looked at targets and personalization. Today, in episode 4, we move into pharmacology, specifically first-line therapy. Metformin remains the foundation. Unless contraindicated, it should be offered to virtually everyone. It is weight neutral, carries a low risk of hypoglycemia, and has cardiovascular benefits. It should be titrated gradually, starting low and increasing over several weeks to minimize gastrointestinal side effects. Dosing adjustments are required in renal impairment, and it should be stopped in acute illness because of lactic acidosis risk. But here is what has changed in recent years. Gliflozins or SGLT2 inhibitors now sit alongside metformin as frontline therapy in patients with established cardiovascular disease, heart failure, chronic kidney disease, or those at high cardiovascular risk. This is a major shift. The evidence shows that gliflozins not only lower glucose modestly, but also reduce hospitalization for heart failure, slow the progression of CKD, and improve cardiovascular outcomes. Let's look at a case. A 57-year-old man with type 2 diabetes, hypertension, and a history of myocardial infarction. 10 years ago, we would have started metformin and maybe added gliclazide if HbA1c remained high. Today, we would start metformin, but as soon as it is tolerated, we add a SGLT2 inhibitors to reduce his cardiovascular risk as well as his glucose. What about patients who cannot tolerate metformin? If they have cardiovascular disease or high risk, then SGLT2 inhibitors monotherapy is recommended. If they do not, then the options widen. A gliptin, a sulphonylurea, pioglitazone, or even a SGLT2 inhibitors depending on patient profile and preferences. There are some important caveats with SGLT2 inhibitors. Patients must be counseled about sick day rules since both metformin and SGLT2 inhibitors should be stopped during acute illness. They should understand the signs of diabetic ketoacidosis, which can occur even at relatively normal blood glucose levels, especially in those on very low carbohydrate diets. Genital infections are common but usually mild. Patients should be encouraged to maintain good hydration. Now let's think about a clinical example. A 64-year-old woman presents with newly diagnosed type 2 diabetes and stage 3 chronic kidney disease. 10 years ago, our options would have been limited. Today, metformin can still be used if her eGFR is above 30, but we would also offer dapagliflozin or empagliflozin for renal protection, regardless of her HbA1c. That is how much the paradigm has shifted. Rescue therapy is another important concept. If a patient presents with symptomatic hyperglycemia, such as polyuria, polydipsia, or significant weight loss, insulin or a sulphonylurea can be used temporarily to gain rapid control. Once stabilized, therapy can be stepped back to metformin and a gliflozin if appropriate. So to summarize, metformin remains the first-line drug, but SGLT2 inhibitors now share center stage when cardiovascular or renal risk is present. If metformin is not tolerated, SGLT2 inhibitors monotherapy is recommended in those high-risk groups, and other oral drugs can be considered for lower-risk patients. Always counsel about sick day rules, risks of DKA, and hydration. And remember, in symptomatic hyperglycemia, use insulin or a sulphonylurea for rescue, then step back once stable. When you next see a patient newly diagnosed with type 2 diabetes, ask yourself, does this person have cardiovascular disease, heart failure, or CKD? If the answer is yes, then metformin and SGLT2 inhibitors are the modern first-line therapy. If not, start metformin, monitor tolerance, and personalize from there. In our next episode, episode 5, we will move to intensification. We'll look at how to step up therapy when HbA1c targets are not met, discuss metformin's mates versus use because you choose drugs, and consider how to make evidence-based, patient-centered choices for second and third line therapy. That's it for today's quick medical review. If you found this helpful, share it with a colleague and subscribe for more clinical gems every week. Until next time, stay sharp, keep learning.